Our next speaker and one of our planning committee members is Matthew Gillman. Dr. Gillman is professor of medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute, professor of nutrition at the Harvard School of Public Health, and director of the Obesity Prevention Program in the Department of Population Medicine. He's very busy. His research interests include early life prevention of chronic disease, including obesity, diabetes, cardiovascular disease, and asthma. Dr. Gillman will present on theory to policy.
Thanks, Deborah. And I want to give some other thanks too before I begin. One is to my colleagues in the Obesity Prevention Program. The second is to Anne and Sherry for wonderful leadership, and to the board and the sponsors for supporting this workshop, which I've found very fascinating. And also to David Barker, without whom none of us would be here. So this is my only slide on theory. You've seen this one before. Our theory is that intervention early at developmental plastic periods will set us on better trajectories of health through a lifetime than if we try to intervene later. Now, let's move to health policy. If we talk about health policy, we can recognize that it's about strategies to improve public health via government actions at the national, state, or local level through legislative or regulatory means. And a subset of health policy is health care policy, in which we try to improve individuals' health via organization, financing, and delivery of medical care services. In developmental origins of health and disease, health care policy is a key piece of overall policy because pregnant women and infants see medical providers for routine care more often than in any other period of the life course. I'm not going to focus on this area. Sherry is going to follow with clinical implications of what we've been talking about. Examples in the area of DOHED of government policy might be cigarette taxes, which reduce smoking not only out of pregnancy but also within. In Massachusetts, in child care centers, that's a regulation to have each child participate in physical activity at least 60 minutes per day. Healthcare policies might include baby-friendly hospital initiatives to promote breastfeeding initiation, duration, and exclusivity, or gestational diabetes screen and treat recommendations, as if there's one of those. There are many. A mixture might be the IOM guidelines for gestational weight gain, which could be transmitted through healthcare or outside of healthcare. The role of evidence in health policy is both to develop and to evaluate policies, and I'll be speaking mostly on developing policies. Well, policy decisions are based on many different factors, and evidence is only one of them. And if we have the wrong evidence or the wrong type of evidence, we might be outside the loop. However, this is what we'd like to think about evidence that drives policy, that it's at the center of the decision making. And so the question is, how can we have the best types of evidence to drive policy? I'm glad to see that the Robert Johnson Foundation puts evidence right in the center. So these are steps that some RWJ Foundation policy development takes, identify the problem and solutions, design and conduct research and demonstration projects to fill gaps in evidence, evaluate those projects, translate and synthesize, engage, and build capacity. So if we think about improving evidence in DOHED for policy translation, it begins with etiology, and that's mostly what we've been talking about today and yesterday, but it also involves thinking about prediction, about risk and benefit, about interventions, about long-term effects, and at the end I'll talk a little bit about policy evaluation. So let's start with the etiology, and this is where I'm going to start getting on shaky ground and probably offend people in the audience, and by the end, I may have offended everybody in the audience. We'll see. So let's talk about how etiologic studies might be more helpful. Let me start with animal experiments with some trepidation, because people who live in glass houses should not throw stones. But I will throw stones at our epidemiology community in a minute. Animal experiments have been great in developmental origins. We can look at exposures and timing and mechanisms and long-term effects on outcomes, and they prove the programming principles. So what's missing often is the things that we have in our randomized controlled trials in human experiments. So often missing are specification of the source population, the sampling frame, the eligibility criteria, recruitment and retention rates, blinding, ITT analyses, attention to missing data, and cluster methods. So a few years ago, Ainge et al. Tried a systematic review of animal models of maternal high-fat feeding and offspring glycemic control. So we talked a lot yesterday about high-fat models, and this is in rodents. They started with 1483 studies, 11 met the criteria. Among those 11, quality scores were low, and there was a large variability in maternal diet. Some were hypocaloric, others hypercaloric, others not stated, and none was an isocaloric high-fat diet. There was a wide range of fat and carbohydrate content, and all of them had different postnatal feeding regimens, age and outcome assessments, so there was no way to summarize or meta-analyze these data. Another way that animal studies could be helpful is what they were maybe 20 years ago, is to follow as well as lead the epidemiology. So animal studies are starting to do these things here on the list, but these are the kind of things that have come out in human studies that would be great to have translated into the animal models. And this, I think, reminds us that developmental origins really is an interdisciplinary field in which there's bidirectional communication between, or multidirectional communication between all of these fields. So animal experiments would be, in my view, great if there was more harmonizing of interventions and measures across studies, importance of publishing null results, and translating up. Well, we're not so great in human population studies, as Caroline and others pointed out yesterday. Observational studies and RCTs have a number of disadvantages. You know, the one that I want to concentrate here is also the one that Caroline was talking about yesterday, which is the main disadvantage of observational studies is confounding. And the main reason we do randomized controlled trials is to minimize confounding. Now, I swear I put this list together before Caroline showed her slides yesterday, but it's about the same list of innovative study designs and analyses that are epidemiologic tricks of the trade to overcome confounding. I also put quasi-experimental studies at the bottom. They're really not about cohorts. They're usually about repeated cross-sectional studies. Interrupted time series are very good for evaluating policies. And again, each of these has its strengths and weaknesses, and it's the totality of the evidence that we should be looking for to be judging. So one example is breastfeeding and childhood obesity. And in 2011, Mary Jo Briand published that wonderful paper that Caroline referenced yesterday, looking at Alspac and Pelotas. And I was asked to write an editorial for this, so I took the opportunity to summarize the evidence for and against the hypothesis that having been breastfed reduces the risk of obesity, and looked at it in, in terms of all the different study designs, including at the top cluster randomized controlled trials, cohort studies of white and European descent, cohort studies in developing countries and racial ethnic minorities, SIB pair, different confounding structures, reverse causality, and biological mechanisms. And you can see there are entries in each of the yes, maybe, and no columns. And so I came out fence sitting at this point. But this was before the 11-year results of PROBIT, the Promotion of Breastfeeding Intervention trial, were published. This is a cluster randomized controlled trial in the Republic of Belarus, looking at the baby-friendly hospital initiative versus usual care in 31 maternity hospitals and affiliated pediatric practices. And what you can see on the right side of this slide is that there was no reduction of adiposity in the intervention sites versus the control sites. This is an attention to control analysis, and if anything, the beta estimates and the relative risks were above 1, not below 1. So in breastfeeding and childhood obesity, earlier studies suggested considerable protection. More recent studies cast doubt. The PROBIT study is wonderful for a couple reasons. One is, as a long-term randomized controlled trial, it's a good test of causality, but it also examines this policy of baby-friendly hospital initiative. And so if we go back to that earlier slide, we could say that we've been developing policy about breastfeeding on the wrong evidence. But for breastfeeding, it doesn't matter so much because it's so good for other things. And it doesn't cause obesity. Now let's turn to epigenetics and see where this might fall in this translation to health policy. So Andrea Baccarelli showed a slide like this yesterday, showing the approach to epigenetics we're taking in our cohort study Project Viva, looking at prenatal exposures, cord blood DNA methylation at birth, and also repeated child blood DNA methylation in childhood in relation to adiposity and its metabolic outcomes. Now, if we simplify this, we come up with the kind of conceptual model that we talked about yesterday. So we have these exposures, here prenatal factors. We have an intermediate, which is epigenetics, and we have the health outcomes. So epigenetics plays this role of an intermediate between pre and perinatal exposures and obesity-related outcomes. So one role it could play is as a surrogate outcome. So this makes our studies more feasible because we don't need to follow all our pregnant women and children ad nauseum to get to the health outcomes. We have an intermediate that we can use, as long as epigenetics is causally related to the outcomes. But the thing I really want to point out is that the epigenetics has the potential for elucidating mechanisms. And if we go back to the Bradford-Hill criteria, biological plausibility is one of the elements for causal inference. Now, to me, this is a rationale for primordial prevention. If we can say that these factors are related to epigenetics, which are related to the outcomes, we want to back up and then say, how can we prevent those pre and perinatal risk factors in the beginning? This is an editorial I wrote about primordial prevention of cardiovascular disease that just appeared in Circulation last week. And this is about optimizing the socio-behavioral milieu starting at conception or before to avoid these things we know that are related to offspring obesity, like maternal obesity, excess gestational weight gain, gestational diabetes, smoking in the first place. So this is not primarily a medical model, although it can involve healthcare. It reminds us, as Sarah was saying just a minute ago, that experiences, not just behaviors, but experiences in our society get under the skin early in life in ways that affect the course of human development. And as Clyde Hertzman and Tom Boyce said a few years ago, epigenetic regulation is probably the best example of operating principles relevant to biological embedding of societal influences. This is my favorite slide about blame the mother. It says, so I blame you for everything, whose fault is that? Again, reminding us that a lot of our solutions are going to be not at the individual level. Individual behavior is hard to change in restrictive environments. And a lot of the time, what we're trying to look at is changing people's physiology or even their behaviors through policy and environmental solutions. And to my way of thinking, epigenetics is sort of at the right archaeological level to motivate how pre and perinatal factors cause obesity. To me, it's a relatively easy way to communicate from scientists to policymakers. So even I can understand that there's demethylation and remethylation early in pregnancy, and I get what Rob Waterland is talking about when he shows the fat, yellow, short-lived mice and the long-lived brown, thin mice. Just a note of caution, we often talk about how epigenetics and other omics can lead to signatures for prediction, and by prediction we mean separating the risk of one individual from another, or risk stratification. And we might be trying to do this for what we might call precision prevention. But remember that prediction has a high bar of proof. We need to have a high sensitivity or specificity or improve the C statistic or the AUC. It's not just about mild elevations in relative risk. And this is primarily a medical model. I think there's kind of a slippery slope here when a lot of the talk about omics is about developing new drugs based on what we find out about the mechanisms and who is susceptible. But in this field, we have to recognize that drugs for pregnant women and infants are really the last thing that we want to do. So what could we say about prediction? Let's move to the next bullet. Andrea mentioned this study yesterday in which we looked at the risk of obesity at age 7 to 10 years in Project Viva, according to combinations of 4 potentially causal and modifiable pre and perinatal risk factors, which included smoking, gestational weight gain, breastfeeding, and sleep duration in infancy. And you can see on this slide that if you have the optimal levels of all 4 risk factors, over on the left, the predicted probability of obesity at mid-childhood is 4%. The adverse levels over on the right side, the predicted probability is 28%. And if you do a calculation of population attributable risk percent, you can say, if you saved all those risk factors, maybe you'd save 20 to 50% of obesity. Now, okay, population attributable risk percent calculations really do assume causality and modifiability. But at least this kind of prediction model can tell us that multiple risk factor interventions in early developmental periods hold promise for preventing obesity and its consequences. So prediction, in my view, can quantify overall potential benefits of intervening early, can distinguish the most important modifiable determinants, and may vary by population or subgroup. What about risk-benefit analyses? In this whole area, we have multiple outcomes and multiple determinants. Let's take an example of gestational weight gain. We'd like to know what's the optimal amount of weight gain in the era of epidemic obesity, and this is important for updating the guidelines. As you may know, the IOM came out with guidelines in 2009. Optimal gestational weight gain has to take into account short and long-term outcomes for both the mother and the child. And associations with different outcomes differ. So association with preterm may be U-shaped, with small for gestational age inverse, and direct associations with large for gestational age, and longer-term outcomes for mother and child, postpartum weight retention and childhood obesity. Now, in this paper that we did from Project Viva, what we did was we looked at the average probability of all 5 outcomes together, and then we looked separately at the risk curves for obese, for overweight, and for normal weight women. And what we could say is that, at least in these observational data, the optimal weight gain should be the nadir of each curve, because these curves are made up of all 5 outcomes. So I can go into more detail later about this, but this is one way of taking risk and benefit when you have short and long-term outcomes and multiple outcomes for both the mother and the child. Another example is rapid weight gain in infancy, which we know is related to later obesity. But we need to remember that rapid weight gain might be beneficial for neurodevelopment. So we have a risk and a benefit, and it may be different in full-term babies than in preterm babies. So this is a summary that Mandy Brown-Belfort and I published a couple years ago, looking at the obesity and cardiovascular risk, the neurodevelopment, in healthy, appropriate for gestational age full terms, preterms, and SGAs, looking at linear growth and gain in weight for length, a measure of adiposity. And you can see where there's insufficient evidence, but you can also see where there's evidence both in the positive direction and perhaps in the null direction as well. So this is a way of taking account of different exposures, different outcomes for different populations. Let me turn to interventions and say that a lot of the interventions in developmental origins right now are efficacy. But we need, for policy translation, we need to move beyond efficacy to focus on implementation for effectiveness, sustainability, and dissemination. And in this realm, cluster randomized controlled trials can be very useful because they are not specifically focused on the individual, they're focused on groups. These are some preventive interventions that we've been involved with in our obesity prevention program, and a number of them here you can see in childhood are cluster randomized controlled trials, and some of their features include health information technology, using the chronic care model, invoking the intervention within an integrated clinical and child care system, and changing the environment of child care centers. But even these, I think, are usually based on one or a few kinds of determinants, or one or a few kinds of settings. And it appears that we might get our most bang for the buck with obesity prevention in young kids with whole of community approaches. So these focus not only on families and individuals and at the center of the social ecological model, but they also focus on these outer rings, including environment and policies. So one of the things I'm excited about right now is a project that Ross Hammond at Brookings Institution and I are leading, which is a collaboration of US, Australian, and New Zealand investigators to look at childhood obesity models for prevention and community transformation. And in this project, what we're asking is, in whole of community obesity prevention in 0 to 5-year-olds, what works for whom and under what circumstances? And what we're doing is applying computational system science modeling to these whole of community interventions, 2 completed interventions, one in Australia and one in the US, one ongoing cluster randomized controlled trial in Australia, and use the modeling that comes out of this to design a new intervention for under 5s in the United States. And in this study, we're really focusing on the upstream implementation part of interventions. Okay, what about long-term effects? So for long-term effects of what happens in early life, we want to know effectiveness, but we also want to know safety, we want to know cost, we want to know cost effectiveness. And really the only way to integrate the data from multiple sources is simulation modeling. And there really haven't been many of these in the world of DOHAD. One that I've been involved with was actually among older children and teenagers, looking at the effectiveness and cost effectiveness of blood pressure screening. Here we had a 2-stage model structure. On the right, there was an existing coronary heart disease policy model that took risk factor levels in a Markov simulation model from age 35 to death to estimate costs and effects. And we appended to that some data that we had on blood pressure tracking, screening, and treatment from childhood to age 35. And we applied that to the US population of 15-year-old adolescents in 2000. And we compared several screen and treat strategies with population-wide strategies. The bottom line of this analysis was that population-wide policy approaches, here salt reduction, increased PE classes, or individual exercise programs, were both more effective and less costly than any of the screen and treat strategies. This brings us back to the Jeffrey Rose principle, the strategy of prevention, where if we shift the distribution of risk factors by a small amount over an entire population, we might be doing just as well as we do if we screen and intervene on a high-risk population. So I want to end by just talking about a couple natural experiments which evaluate policies. So this was our actual very first publication from Project Viva, which took advantage of the fact that our recruitment straddled the first warnings to pregnant women to eat less fish that had mercury in it. And what you can see in this interrupted time series analysis on the blue line is that before the warning, in that 2 years, the fish intake was gradually increasing. Right after the warning, there was a noticeable drop, and in the subsequent year, there was a downward slope, so even less eating of fish during that period. So this time series analysis showed a couple of things. One is that even an intervention that wasn't very strong, so this policy was promulgated through obstetricians' offices, and there wasn't really a great implementation strategy, had an effect on mothers' eating habits. And so that makes us think that, you know, mothers are concerned about their growing fetus, and they may be willing to change behaviors that they wouldn't other times in their life course. The downside is this is the wrong behavior to change, but that's another story. And Emily Okun, who published this, has spent the last decade thinking about the risks and benefits of eating different kinds of fish from ecologic, economic, safety, and hazard perspectives. One that we published very recently with Summer Hawkins, who was a former postdoc, was looking at associations of tobacco control policies with birth outcomes using a quasi-experimental approach of repeated cross-sections of US natality files from 28 states. And we found that increases in the cigarette tax were associated with improved health outcomes related to smoking among the highest risk mothers and infants. These are the lowest educated. So considering that states increasing cigarette taxes for other reasons, not to improve birth outcomes, this is a very good side effect of this policy. And finally, this just reminds me to bring up racial ethnic disparities in childhood obesity. And this paper from Project Viva that Elsie Taveras published now a couple years ago, showing that racial ethnic disparities in childhood adiposity and obesity are determined by factors operating in infancy and early childhood. So our efforts to reduce obesity in early life by changing risk factors in early life have great potential. So just to conclude, to achieve evidence-based policies and their implementation, from animal studies, we could use consistent methods and harmonizations of designs and measures, human studies of etiology, both observation and intervention, innovative designs and analyses, compare and combine across studies, and epigenetics, I think, can help us with science to policy communication. Prediction models tell us about potential intervention targets. Risk-benefit estimates can help us with guidelines. Intervention studies beyond efficacy and looking at implementation can be very useful. Long-term simulations, including cost-effectiveness, I think play a large part. And we can evaluate current policies for their impact. Thank you very much.